Welcome to the Vet Dental Show. I'm Brett Beckman, board certified veterinary dentist, and we bring this podcast to you every Wednesday as a veterinarian, as a technician, as a dentistry team to help you be even better at veterinary dentistry in your practice. We're sponsored and partnered today with the Veterinary Dental Practitioner program. If you're interested in being among the best anywhere in general practice as a team in veterinary dentistry, I invite you to request an invitation. Just go to ivdi.org/INV, like invitation, first three letters INV. So IVDI, International Veterinary Dentistry Institute, ivdi.org/INV, and we'll get you the information that you need.
When we're talking about protocols within a general practice where you've got multiple doctors, and one doctor does it one way and the other doctor does it the other way. And this can be extremely challenging, and I've worked at a practice where we had 10 doctors on staff, and we made it a point to achieve a more, like you say, linear standard of care where we're kind of all on the same page. And so it took time, but especially in the dental suite, if we're keeping that staff small, then we should be able to sit down as adults, as a group of that dental team, and establish appropriate protocols specific to those dental patients. It may not be across the board for, spays and neuters and some of our other surgeries, but within the dental suite, I would suggest getting that team together and working your way toward trying to establish a consistent standard of care within that hospital. And you are not the first one to face this challenge. And depending on how progressive, how open-minded your practice manager, owner, doctors are, the easier it's going to be. I would suggest that the docs that you have on the team get education with some of our courses to keep them educated and help you stay in alignment with what we're recommending. Because this is not just something that, that we're teaching. This is something that all of the diplomats recommend with regards to full mouth x-rays on every patient, keeping them light under anesthesia, providing appropriate pain management with nerve blocks. All of these essential components that need to go into a very high level of standard of care specific to the dental patient. So it really requires having some adult conversations and really working towards trying to get that dental department, where it needs to be. And it's easier to do that keeping the team small, keeping the lines of communication open, and having some open-minded folks who want to achieve the same goal. So good luck. And again, you're not alone. This is very, very common throughout a lot of general practices. But I will say that those general practices that embraced dentistry, created a very efficient, high level of standard of care, have really done wonders in improving and adding to their bottom line and creating a dental department that sets them apart from other practices in their area. And they have really become successful practices because of that dentistry center, that dental suite, doing those procedures the way that we recommend and efficiently the way we recommend, and have shown some really, really good success.
One of the techs at work had a patient lights for dental x-rays like we recommend, which is absolutely wonderful. However, we were a little bit too light and that sensor got damaged. Been there, done that. It's not a great feeling. When I first started with Dr. Beckman, I did the same thing. I wasn't used to the light anesthesia. And, that propofol wore off. By the time I got around to the left side of the maxilla, that patient was just too light and bit down on that sensor. And so here is another tip for you to help avoid damage to your sensor. I place either a little dental gag, whether it be compressed rolled up gauze or hard curler, something where we create a space, number one, to have that sensor positioned easily between those carnasial teeth, because that's where the damage is going to get done. And so anytime we're imaging the caudal maxilla from the fourth premolar back, I'm going to have that gauze in place to create a space for the sensor as well as protect my sensor. So when I put that gag in, the next thing I do is I push down on that muzzle and make sure that that gag is sturdy enough that I'm not going to be able to close that mouth all the way. That will help us avoid damage to the sensor should that patient be too light. The other thing, when you put that gag in initially, if your patient is too light and you kind of push that back there way between the last molars on the top and the bottom, you're going to push it all the way to the back of the mouth. When you do that, if they're too light, it's going to stimulate them and they're going to bite down. That's going to give you the tip off that you need to ventilate them a couple of times to get them a little bit deeper before placing that sensor. So this positioning helps with avoiding that. And then as soon as we're done imaging from the fourth premolar back and we're starting on the first, second, and third premolar, that gag or that gauze can come out, and then we can let the mouth close the rest of the way, because those premolars don't need enough to damage that sensor. It's just primarily in this area where we have issues. So that's a habit that you just need to establish, and remind yourself for every single patient to put that gag in, and then you shouldn't have any problems. Why don't we need to take a dental radiograph of the entire tooth? You mentioned only taking a radiograph of the root. What we're evaluating when we take dental x-rays is from the alveolar bone to the apex. That's where we can't see. The crown we can examine grossly. And if there's discoloration, if there's a fracture, we're going to want to see if it's open or complicated. We're going to want to see if the tooth is vital or not. And we do that on the dental x-ray. So any x-ray, we don't need the crown. That being said, most of the teeth we're going to get from crown to root. The only teeth in most medium to large size dogs is the canine and the first mandibular molar. Everything else you should be able to get from the alveolar bone, from the crown to the root. And the reason that we don't worry about the crown, we certainly can x-ray the crown, but it's going to take another view, which is a few seconds added on. And that's okay if your doc absolutely needs that, but it's not necessary. We can look at the crown grossly. What we're evaluating is alveolar bone to the apex. And when we're looking for pathology on the status of that tooth, the x-rays are what we rely on primarily, unless we're looking at earlier changes like periodontal pocketing, an open, root, an open pulp chamber where we use our Explorer. But that's done grossly. But we need to establish the status of that tooth, whether it's vital or not, if there's any bone loss around it, if we have a wide pulp chamber that tells us that that tooth is non-vital. So all of those things we see radiographically. So we really don't need to have the crown on there because we can see that grossly. The other pathology that we need to see is primarily the information that we get from the radiograph from alveolar bone to the apex and specific structures. Do we do dental radiographs on all pets regardless of age? Do you take radiographs post-extraction to make sure we get the root? And do you always want to debride after extracting a tooth? The answer to these questions is all yes. If they have their adult dentition, regardless of age, so if they're 6 months, 7 months, 9 months, we are going to do full mouth radiographs. And you would be very surprised to see how many surprises or unexpected pathology that we find. For instance, we do have patients come in that are 6, 7, 8 months of age that may come in for maybe deciduous extractions or malocclusions, those young dog issues. And so our standard of care is to take full mouth radiographs. We find things like impacted teeth, unerupted teeth. We find sometimes changes in the bone. We'll find extra teeth that haven't erupted up in the bone. There's a lot of different pathology that we find on these younger patients that wasn't expected. And so we never ever want to guess. When we treat these patients, we don't have tunnel vision. We're going to evaluate everything. While we have them under anesthesia, it is just much more effective and a much better standard of care to evaluate. We absolutely do post-extraction radiographs. If we leave roots behind, that can be an issue if we miss that. And so we are always doing post-extraction radiographs. So we want to make sure that we're extracting those teeth intact. And then we want to make sure that we're, Dr. Beckman does that debridement, especially for periodontal cases. We want to debride all that infected bone and tissue in a lot of cases and close with healthy margins so that these patients heal appropriately and then they do much better post-operatively. And so we always want to make sure we're doing a post-op x-ray. Do you have multiple size sensors to use on large breed dogs? And this is a pretty common question that gets asked. And depending on which x-ray system you have, the direct system that plugs in directly into the computer is a number 2 sensor. It's just not cost effective to have different sizes because most folks can only afford one because those sensors are sometimes cost prohibitive. However, if you have the indirect where you have the advantage of having different size plates, the phosphor plates, where you can have that number 4, that is an alternative. However, there's that extra step of putting that into the digitizer to get your image instead of it being instant. I will say that I can take x-rays on everything from a 3-pound Maltese to a 180-pound Irish Wolfhound with a number 2 sensor. Again, it takes practice and just doing it over and over and over again, and that isn't an issue at all. So that's something that right now looks daunting, but absolutely is doable with a number 2 sensor. No worries. What do you do if on exam a tooth looks compromised, but on x-ray seems fine? And this is a great question because we never ever make treatment decisions based on either gross pathology or x-ray alone. We put those 2 components together to give us a more comprehensive picture because that can happen where the tooth has significant pathology, but we just can't appreciate it on the x-ray. And so we are going to put that picture together. So depending on how compromised, if we have a really deep pocket, for instance, a maxillary canine, where we probe on the palatal side and it goes, all the way up into the nasal cavity, but the x-ray looks okay, obviously that's going to be an extraction because we've got an oral nasal fistula there. And sometimes with those soft tissue changes or bony changes, depending on what position that x-ray was taken. You may not appreciate it on that x-ray. So absolutely, we are going to trust both gross pathology as well as radiology, and put those two together and then make that treatment decision.
I hope you enjoyed that episode. If you'd like more information about the Veterinary Dental Practitioners Program, please submit to request an invitation at ivdi.org/INV.